Again, my sincere apologies for rushing between halls. I guess we couldn't help it. This is a presentation on diabetic TRD and vitreomacular traction. At the outset, I would like to thank Dr. Giridhar for having invited me to be a part of his course. We all know that there are two important locations when surgery would be required in diabetic retinopathy management in terms of non-proliferative diabetic retinopathy as well as proliferative diabetic retinopathy. Even in the milieu of NPDR, epiretinal membranes and VMT could be an indication for surgery. And in PDR, of course, we know lots of indications which will be discussed by various speakers in this session. So is pre-retinal traction always an indication for surgery? If you see these cases, they look quite significant traction pre-retinally and retinal thickening. But does that mean, and this is a vitreomacular traction, but we do admit that the vitreous is not that condensed like what we expect. So would these be indications for a vitrectomy prima facie, or would you like to attempt anti-VEGF? So this is the same cases, pre-injection, post-injection. As you can see, there has been reasonably good response, although the pre-retinal membrane is still quite thick here. The macular edema is resolved. And the recurrence occurred only after 4 to 5 weeks, which could occur even in eye without pre-retinal traction. So presence of pre-retinal traction doesn't always mean surgery is mandatory, but somebody who is not responding, then of course you would definitely consider. And again, it's a gray area. There are a few cases where you say it will never respond, you will definitely go in for surgery. So in a DME with ERM, the options are surgery to remove the epiretinal membrane and also administer anti-VEGF at the same time. Or you give anti-VEGF, see the efficacy. If efficacy is good, sometimes even they're like partial vitreous detachment can become a total PVD across the macula, and there may be no more residual traction. But in the presence of a membrane, you would definitely ignore sometimes in cases where there are other reasons for poor vision, like an optic atrophy, a totally sclerosed vessels, in general a very poor prognostic eye with a lot of macular ischemia. You're not worried about a little bit of pre-retinal traction there. The problem is much bigger than just the pre-retinal traction. So in coming to diabetic TRD, which is in the milieu of a proliferative response, one should understand the pathoanatomy, when the posterior vitreous detachment is present or not. And we know by present, I mean even if it is present in a small location. We know that PVD will never be total in a case of diabetic retinopathy unless in very select cases. In most cases, it will be stuck in some place or other due to the abnormal fibrovascular attachment. But when we say present, is it present at least in some locations? Because that makes our surgery a lot more easier. The severity of vascularity, and one should understand the concept of vitreoskisis, wherein the vitreous is split into multiple layers, and each layer can be fibrotic. So it's not that there's just one second membrane and one PVD. There can be multiple membranes, and each would need to be addressed in your surgery. The extent of retinal ischemia and the consequent thinning, which is what dictates how much traction the retina can withstand when you do the dissection. And the strength of the vitreoretinal attachment, that is the ease with which the membrane can be removed. Is it peeling or is it cutting that is required? This picture just gives you an idea as to how you as a surgeon can assess what is the degree of difficulty you're likely to face when you do vitreoretinal surgery. Now this is an eye where the retina looks not too bad, and there's a pre-retinal membrane, pre-retinal hemorrhage, which tells you obviously that there is vitreous separated on this area. And there is some amount of gliosis, but not too much of TRD, etc. So likely that surgery could be fairly simple, where you just open up this area and extend the vitreous detachment all around, and the whole thing can get lifted up. But there are always situations where there are areas where it's strongly adherent, and if you're not conscious of the fact and violently detach the vitreous, you can actually tear the retina. Now consider this case where the retina is a little more ischemic, the disc is more pale, and you find again a pre-retinal hemorrhage, which tells you that in this area, definitely the vitreous is likely to be detached, and this can be a starting point for your dissection. While the case on the top right is a little more advanced disease, where there's a TRD, likely there's no PVD at all. You get a large fibrovascular tissue which is pulling on the retina. But here also you can find sometimes planes of dissection to start with. But this is probably the worst case scenario where you find a florid disease, very thick fibrovascular tissue, but see the retina on either side of this area. It's absolutely ischemic, there are no vessels seen, and the whole thing is pulled down. So this surgically is going to be a lot more difficult than the first three versions. So some amount of idea you'll have. When do you operate in diabetic TRDs? We all have been taught about extramacular versus TRD involving center of the macula. I don't think there's any controversy. But what about TRDs bordering on the macula? That's where the controversy arises. When you assess it clinically, sometimes you're not sure whether the macula is actually involved in the traction or not. But OCT comes to our rescue. It tells you exactly whether the fovea is detached or not. There may be thick membranes in front, but OCT cuts through everything and tells you precisely the anatomy of the fovea. And there are many cases where preoperatively our clinical examination told us we should operate, but OCT told me we should not operate. And you should also match the visual acuity to the macular traction. There's also confusion sometimes between a trampoline membrane, which is across the macula, versus actual traction on the macula. The membrane can be going, bridging between the arcades, but may not be actually pulling on the fovea at all. And these patients can have excellent vision as long as the fovea is not ischemic and not unhealthy. How about extensive TRD all around the macula, but macula is still attached? These patients may deceptively having good visual acuity, but they have hardly any field of vision. And functionally, they are really not good at all. So you may be having 612 or better vision, but all around the fovea retina is detached. There may be indications for surgery despite visual acuity. So visual acuity is not the sole criteria for deciding when to operate. What about possible reasons for not operating? A very thin atrophic retina, grossly sclerosed vessels, and gross optic atrophy. I'm sure each one of you in this hall must have had experience where each one of these are not a contraindication for operating. That despite a pale disc, despite sclerosed vessels, and despite a thin-looking retina, they have recovered useful vision. So these are all relative contraindications. I'm not saying absolute contraindications. So ultimate decision maker is your assessment of what is the visual potential versus the anticipated complexity of surgery. The basic principles would revolve around core vitrectomy. I can't stress too much on the need for debulking the vitreous. Leaving too much of vitreous in the periphery, as we used to do in the pre-wide angle visualization era, is not a good option at all. So you must remove most of the vitreous gel. You may do it before inducing PVD and before initiating a membrane dissection and before leaving peripheral vitreous undetached. Means you have detached the vitreous in the posterior pole, but the whole peripheral vitreous is stuck. When it is stuck and you know beyond this I can't detach it, at least debulk it. So don't leave it like a thick vitreous gel in the periphery stuck to the retina in the periphery. So before all these three steps, you must debulk the vitreous. What about membrane dissection? You can do as a combination of peeling, delamination, and segmentation. I won't go to the details because ultimately it's what you are comfortable with, and in a given case scenario, you may switch from one to another back and forth. A divide and conquer is a useful technique rather than trying to remove it en bloc, because that makes it easier for you, number one. Number two, you can also judge the anatomy underneath the tissue rather than having an opaque tissue covering your area of dissection, and it also allows you not to create retinal breaks at a faraway point when you're dissecting at one location. Attempt not to leave residual tissue. I said attempt because there are cases where you think you push yourself to a limit and say, beyond this I'm going to cause a break. Maybe it's best to leave a residual tissue than cause a break, especially if the tissue is nasally located or far away from the equator where it's not likely to cause traction on the macula. Let's just take a sample case. I thought no presentation on diabetic TRD would be complete without showing a video. It's just to show you that you can keep the cutter on the tissue and cut towards you, so there's no risk of retina getting sucked in. And this technique used with the 25 gauge instrument is probably enough to remove most of the scar tissue in diabetic TRDs these days, where you cannot use, always divide and conquer and then use the scissors to dissect. With the with the 25 gauge instruments, your need to use cutters, scissors is far less than it used to be in the past. So you can see the vitreous, which is not even visible, was actually detached, and that enabled the delineation of actual fibrovascular attachment, which could be cut with scissors. And then, of course, the next step is very easy. So the initiating the membrane dissection is different between the 20 gauge instrumentation technique with 23 and 25 gauge. With 25 gauge forceps, you don't need a sharp needle, you don't need a scratcher, etc. Directly with the forceps, you can hold the membrane. Since you can hold the ILM, you can hold this membrane as well, and then try to dissect it. So you always catch the membrane at where it is least taut, not the taut membrane, because that doesn't lend itself to grasp. So you go beyond at a point where it's hardly visible. There you can catch it, then you can hold it easily and peel it towards the more strongly attached, more densely fibrous tissue. Pulling the plug over the disc also gives you a large area of separation around the posterior pole from where you can dissect into the periphery. It's always preferable to dissect from periphery to center, but there's no dogma. You can always start from center as well. But because the central vessels connecting the vessels, fibrovascular tissue to the retina are more thicker, they can bleed a lot more. So you prefer to start from periphery and then come to the center. So this change in approach with MIVS, especially 25 gauge. Okay, I think I'll quick slip this video. Beware of iatrogenic retinal breaks, breaks that can occur at a point remote from the area of dissection. Breaks can be camouflaged by pre-retinal hemorrhage. There's a difficulty in differentiating between a thin retina and a broken retina, and a surgeon goes into the mode of denial, thinking it's not a break, it's not a break. Better to think it is a break and treat it at this point of time than trying to avoid treating it, okay? Management of intraoperative bleeding, good control of systemic status preoperatively. GA is preferred in florid disease, preoperative anti-VEGF, intermittent raise in infusion pressure, etc., etc. And the story goes on and on with the next speakers. Thank you very much for your attention, and again, my apologies for leaving you early. Thank you.